Leukocytes. Let's talk about some leukocytes. We've been focusing on erythrocytes. Let's have a focus on our leukocytes. Leukocyte means white cell. And we have these different types of cells. There are quite a few categories over here, down here in the lymphocytes, but we have basophils, eosinophils, neutrophils, monocytes, and lymphocytes. Those are all the different types of our white blood cells called leukocytes. They're all for immunity, but I want to point out the word leuko means white, leukocyte. Lympho, for some reason, some students get this confused. Lymphocyte, leukocyte may sound the same to you, but a lymphocyte, remember, it belongs in the lymphatic system, just a little helper along the way. So don't identify this on your lab practical as a leukocyte. It is a leukocyte, but you'll get it wrong. It's a lymphocyte. All of these are leukocytes. What are they for? They're for immunity. And here are some vocabulary words. These leukocytes are, first of all, they're born. There's a previous lecture that I did on hematopoiesis. You might want to go back and look at that lecture. But in the bone marrow, you have a hemocytoblast that's going to differentiate into one or two stem cells, either a myeloid stem cell or a lymphoid stem cell. And if it develops into a myeloid stem cell, it can develop into platelets or erythrocytes or most of our white blood cells. If it develops into a lymphoid stem cell in the process of hematopoiesis, then we can end up with this cell down here called a lymphocyte. But they are born in the bone marrow, then they enter the bloodstream. So say this is our typical white blood cell in the bloodstream. And then we've got some tissue out here and it has an infection, maybe a splinter or something like that. Well, the dead and dying cells or injured cells are releasing chemicals. And what they're doing is they're trying to attract these different types of leukocytes to the area by chemicals. So if you attract leukocytes to the area by chemicals, that process is called positive chemotaxis. The white blood cells are following a chemical trail. But how do the white blood cells get through that blood vessel? They do it through a process called diapetesis, slipping between two endothelial cells. Well, endothelial cells are simple squamous cells with a special name, simple squamous. Some people say squamous, I don't care. The simple squamous cells are lining the inside of the heart, say, or the blood vessels. If they're lining the inside of blood vessels or the heart, we specifically call them endothelial cells. And so if this white blood cell slips between two endothelial cells, that is called diapetesis. We can also call it extravasation. Now, once the white blood gets through into the tissues, out here's the tissues and here's the blood, it starts to creep along. So it moves through the tissues through a process, through a motion called amoeboid motion, because an amoeba is a little single-celled organism that forms these pseudopods and crawls around. So get an idea of what these guys look like. They're all white blood cells. You have to identify them on your lab practical. And the basophil, this guy right here, oh, wow, I didn't know I could do that. Look at how different the basophil is. See these little black granules? Let's see. See the black granules in here? All of that. They're so dark, etc., that they obscure the nucleus altogether. And then these are all the granules in here. These red granules in the eosinophil granules, there's little staining regions, staining packets of good stuff that the white blood cells use. They're red. And so you can see the nucleus here. You can see the nucleus here. Let me get myself out of this view. I've confused myself. Okay. Let's stop for a second and let me. Okay, I was just rambling because I was stuck. I was very excited that I could make that screen bigger and that I couldn't figure out how to get down. Okay, the basophils, they have the dark staining granules. And the reason they're called basophils is because the stain that is used to stain these. They're all white blood cells. So if you look through the microscope, you might not see them unless they're stained. So what kind of stain is the best stain for a basophil? Well, a basic stain that stains a very dark blue. So the term basophil comes from the fact that it stains the best with a basic blue dye. Eosinophils get their name because they stain best with the dye called eosin, which is red. It's an acidic dye. So it's more of acidic dye that these eosinophils take. And so they have red staining granules. And then we come to the neutrophils. Well, if you take a base and an acid and put it together, you can neutralize them, right? And so what does red and blue make? Well, a nice little purple, a lilac color. And so this guy right here has a lilac background because it takes equal amount of the basic and acidic dyes, hence the name neutrophil. Phil means loving. So you can see, you look at those first three pictures, they look different from one another. This one has a bunch of dark staining granules that are dark black, blue. This eosinophil has a bunch of dark staining granules that are red. This guy, now this nucleus may look really weird to you, sort of like this nucleus here, but I can tell you that the eosinophil has a nucleus that looks like this. By the way, if you can't see that these granules in here are red because you are colorblind, you have to look at the nucleus to identify the eosinophil. And the nucleus looks like this. Bilobed, it has a thick, like Snoopy ears. Now you're like, that does not look like that, right? Well, you got to think if you're looking on like this, or if you're looking at any angle, etc., it's going to change the view. So I try to get a really good view for your lab practical. Now, when it comes to the neutrophil, look how crazy this really wild coming at you nucleus is. It has this weird shaped nucleus. First one, in the basophil, we don't see a nucleus at all because it's obscured by these granules. The eosinophil has this Snoopy ear type bilobed nucleus. And this next one has this multi-lobed nucleus with a lilac background. So they do look different, don't they? When we come to these last two, look at this one. It's a blue, but also look, I want you to draw attention to this on the monocyte, the shape of that nucleus. If you see a beautiful U-shaped nucleus in a very large cell, it's going to be a monocyte. And the last one, they've enlarged this guy, but what you'll notice is the nucleus takes up most of the space of the cell, and we just have a little rim of a lilac cytoplasm around it. And so while you're looking at these and you're thinking, yeah, those are white blood cells, be aware that you have to be able to identify them. In a perfect situation, it's a freshman level class, but still, we can lump these leukocytes into two main categories. Do they have granules in them that stain? Granulocyte. Are they a cell with granules that stain? Or are they a cell with granules, without granules? Because if you put an A in front of something, like amitotic means there's no mitosis. Atypical means it's not typical. Agranulocytes mean no granules. And so if you don't have dark staining granules, there are two that don't have dark staining granules. Those are our lymphocytes and our monocytes. Here's our monocyte, same picture as before, and here's our lymphocyte. They don't have those dark staining granules in the cytoplasm. While the granulocytes, we definitely see dark staining granules here. And in the eosinophils, you have a nice red dark staining granules. It's better underneath a microscope. In the neutrophils, you might not see many dark staining granules. It has that lilac appearance in the cytoplasm, but the nucleus has so many different lobes that are like, oh, okay, that's neutrophil. Does it look like anything else? It's a neutrophil. So our granulocytes would include our neutrophils, eosinophils, and our basophils. And for the most part, those guys are phagocytic, meaning they're cells that eat things. They have the capability of killing in a variety of ways, but if they can reach out, engulf something and take it in and dissolve it, that's a phagocytic cell. Whereas some of our agranulocytes are not phagocytic, so that is not in your list there. Now, what are our leukocyte numbers? Like if you looked at a stain of blood, if you just grab a sample and you stain it and you look at the different distribution of the white blood cells, we're going to find out that some of them are way more abundant than others. And those will be the neutrophils. You're always going to see a neutrophil. You're just going to see a neutrophil. If you scan around the slide, you will see a neutrophil. And most likely you'll see a lymphocyte because they make up 40 to 60%, the neutrophils do, of the whole, not the whole blood sample, excuse me. Remember, in our whole blood sample, we have the hematocrit, which is the percentage of red blood cells or erythrocytes at the bottom. Then, only representing 1% of our whole blood count, we're going to have what's called the buffy coat, which consists of platelets and of white blood cells. And up here, 55% approximately is going to be the actual liquid portion of the blood or the plasma. So we have all of our formed elements here. If we look at this 1%, this buffy coat, and just look, take the platelets away, and just look at the leukocytes and say, what are the numbers? Then we're going to find that neutrophils take up 40 to 60% of the leukocyte numbers. Lymphocytes take up 20 to 40% of that share of the leukocyte numbers. And our typical leukocyte count is between 4,500 to 11,000 per microliter of blood. Monocytes are significantly fewer in the blood. And then our eosinophil count and our basophil percentage. These are normal percentages. So we're going from most abundant to least abundant. And there is a mnemonic: never let monkeys eat bananas, to help you remember going from most abundant type of leukocyte to the rarest type of leukocyte in a blood sample. I don't like monkeys. Okay, let's talk about our neutrophils. Neutrophils. So if you look, all of these guys, there are 4 neutrophils on this slide. 1, 2, 3, 4. This one is positioned in the best way that we can see how weird the nucleus is. It's called the polymorphonuclear leukocyte. Polymorphonuclear, meaning many-shaped nucleus. Because for a reason, the nucleus may look different every time you see it. But what you'll see is that pale background, that lilac background where it takes up the red and the blue dyes equally. And you'll see how many different, they're the most abundant ones. So statistically speaking, if you're looking at one, you're like, oh yeah, that's a neutrophil if you're looking at a slide. I want you to also notice on this slide that we see our red blood cells. These are all red blood cells, all of these guys that look like this. And then we have some platelets on this side. So don't forget to look at the other stuff on the slide. Our neutrophils are our most abundant white blood cells. They're our main bacteria killers. They can cause inflammation. They're just very important in the body. They are our most abundant, between 40 and 70% of the white blood cell count. So we depend on them for a lot. And their lifespan can be hours to days, because if you remember the lifespan, we did this hematopoiesis is the term for making blood. And we did this in a previous lecture, and we also followed up and did specifically our white blood cells, leukopoiesis. That's the formation of our white blood cells. That hematopoiesis and leukopoiesis occurs in our bone marrow by the hemocytoblast. And that hemocytoblast, in this case, will differentiate into a myeloid stem cell. Please refer back to that lecture. And that myeloid stem cell can become erythrocytes and platelets and all the other kinds of white blood cells as well, except for one type. And it will become eventually this neutrophil. neutrophils are very significant infection fighters and inflammatory causers in your body. They last hours to days because as soon as they're called into action, they're going to go and they're going to kill themselves for the cause. So think of these guys as one of your main lines of your innate immune response. In your innate immune system, all of the white blood cells that we're listing today are part of your innate immune system, except for one type. And I'm going to point it out coming up in a future slide. But innate means to be born with, right? And so our innate immune system is anything that basically they're just a generalized way that we can fight off infection and stay alive. Right? So your innate immune system is going to be, let's take all these white blood cells, neutrophils. They're not specialized for a certain virus or a certain bacteria. They're killers. That's what these neutrophils are. They'll go out and they'll kill a bunch of stuff. That is a part of your innate immune system compared to, Google this, your adaptive immune system. And in your adaptive immune system, it's going to be involving only one type of white blood cell, not on here, but we're not going to mention it yet. Think about antibodies. And we've discussed antibodies in a previous lecture when we talked about the different types of blood types and how we have, with the blood types, we have preformed antibodies when we're talking about A and B antigens. But when it comes to RH antigens or the D antigen, we don't have those preformed antibodies, and we have to be exposed to, most of the time to develop antibodies, we have to be exposed to a foreign antigen, and then we develop an antibody. So our innate immune system is something that acts very fast. We're born with it. It's there to help us. But then this adaptive immunity is a slower process, but this is fast in general. This is slow and specific, very specific when we bring antibodies into the story. Okay, so these neutrophils are our first player in our innate immune system. When we get to the eosinophils, they're also a part of your innate immune system, except for they are a little more specific than the neutrophils. They are going to be the known allergy, asthma, parasitic worm, leukocytes. In other words, if you have high eosinophil counts, it's the first thing they're going to think of. The first thing would be allergies. Second thing, hopefully the second thing, would be parasitic worms, because these guys will be elevated in the case of both. People who have high allergies tend to have eosinophilia. If you put the name of the white blood cell before the word philia, this means loving, but in this case, it's high eosinophil count. If you have low eosinophils, sometimes you can have low eosinophils. Eosinophilia, eosinopenia. Penia means poor. And so if you have low eosinophils, that can be caused from certain medications and certain disorders, but then it would be called eosinopenia. Too many different ways that we can cause eosinopenia to bring that up in this lecture. But note, when you think eosinophil, think allergies and worms, they have a lifespan of a few days, and they're very abundant in the respiratory and digestive passages. And if you think about it, that's mostly the way, besides through the skin, that a parasitic worm is going to enter your body. It's going to come into your respiratory center or through the digestive tract. And so it's great that we have these eosinophils that can help fight off parasitic worms in these areas. However, it's not really great if you have a lot of allergies. And if you have a lot of allergies, because they're abundant in the respiratory and digestive passages, it can cause inflammation in these regions. It mediates the asthma attack, the asthma inflammation within those bronchial tubes. In the digestive passages, if you have eosinophils that infiltrate, say, the esophagus, then you might end up with eosinophilic esophagitis, as the name suggests. we have inflammation of the esophagus, and it's due to infiltrations of eosinophils into the esophageal walls, and that will cause the esophagus to close up. So some people with a lot of allergies tend to all of a sudden now I can't swallow, things are getting stuck in my throat. It could be eosinophilic esophagitis, and there are medications for that now, so that's a good thing. Here are our basophils. Our basophils are our last type of granulocyte. We have the neutrophils, the eosinophils, and the basophils. They're all granulocytes because they have those dark staining granules. And notice here we can't even see what this nucleus looks like because it's covered with these dark staining granules. And a lot of the granules contain histamine. They contain many things. Histamine causes an inflammatory response, which is one part of this inflammatory response is histamine will cause the blood vessels to become leakier, and fluid will come out of the blood vessels into the area, press on the nerves, cause it to be warmer, cause it to have pain. That's what inflammation feels like, right? You know, you might have a warm patch that's a little in pain. Histamine is one of those inflammatory chemicals, and these basophils have them. Now, I'm not saying it's just basophils that cause the inflammatory response, but it's just the easiest way to remember. These basophils are our rarest ones, but they're big players. They can cause all the other leukocytes to be increased in their abundance, and so we like the basophils. Okay, we're getting up to our agranulocytes. And when it comes to the agranulocytes, these lymphocytes here, notice you don't have any dark staining granules in them. Trying to get to where I am. Here is the nucleus, and we have this rim of cytoplasm around. And I smell my lunch burning. I'm taking that as a clear sign, as I should not have been eating what was in the oven in the first place. Okay, I'll start over again on the lunch and the lecture. So these are our lymphocytes, and they have this pale rim of cytoplasm around them, and we have the nucleus. They're very abundant. They're not the most abundant. Neutrophils are the most abundant. Remember, never let monkeys eat bananas. So they're the second most abundant white blood cell. On this slide, we only see red blood cells and lymphocytes, no platelets in the background or any other cells. If you look underneath the microscope, most likely you're going to see neutrophils and lymphocytes. That's just a fact because of their abundance. They last hours to years, and that's because there's a great variety of these guys. We're going to have T cells and we're going to have B cells. B cells and T cells. B cells are going, here they are, B lymphocytes become plasma cells. These guys are part of, what do you call them? They make our antibodies. And these guys, there are a variety of different T cells. There are killer Ts called cytotoxic Ts, cytotoxic T cells that kill things. There are memory T cells, cells that remember what's going on. There are suppressor Ts that once an infection has happened, they've got to slow everything down so the T cells don't go out of control. So there are different types of T cells. This is cell-mediated immunity when the cells are coming into play. This is antibody-mediated if we're talking about B cells or these plasma cells. All right. So we have lots of different types of lymphocytes. They start out in the bone marrow. They come from the hemocytoblast, which then differentiates not into the myeloid stem cell. This is the one where instead of zigging, we zag. We go from a hemocytoblast, boop, boop, boop. Instead of going to a myeloid stem cell, which gives rise to erythrocytes and platelets, all the other white blood cells. In this case, this hemocytoblast differentiates into a lymphoid stem cell. And I really need you to go back and review leukopoiesis, hematopoiesis, erythropoiesis, thrombopoiesis, and look at that lecture so you understand the difference there. But they come from a different type of cell lineage altogether. Even though this is the second most abundant type of white blood cell, not many of them are in the blood compared to the lymph tissues, hence the name lymphocyte. So we develop in the bone marrow, and then the immature cells are released, and they go up to the thymus where they're matured. Thymus releases thymosins and thymopoietins, and it causes the maturation of the lymph cells. And then they take up residence in areas like our lymph nodes and our spleen. Our lymph system are full of lymphocytes. Hopefully you can remember that. And these guys they do so many things. As they directly attack cells or make antibodies, they do so much more than that. These cytotoxic T cells might directly attack something, but the suppressor Ts obviously do not. So this is a mass generalization. But when you think of these guys, think of viruses big time because they have memory. And you know, this is the reason that we get vaccinations against viruses, right? Because we're introducing something that has been killed or weakened. We're introducing a foreign antigen in our body. So in the future, if we get exposed to it, we'll already have antibodies. So viruses, let's pretend like we have a virus that looks like this. Not a virus on the planet looks like this, but it has these funky antigens on it. When we take a vaccine, we kill this guy and we only inject the antigens into you, and then you have the immune response. These lymphocytes are going to develop into plasma cells. They're going to make antibodies, and then we're going to have antibodies in our blood for whatever this virus is. Let's call this virus Bob. So now we're going to have anti-Bob antibodies in our system. And if Bob ever comes back into our body, we'll have antibodies to fight off against that. So they're very specific. The first time you're introduced to something, you're not going to have antibodies, right? So you will get the sickness. But that's the basis of our vaccines, to make sure that if we actually do come across a really nasty virus, we'll have immunity, adaptive immunity against it. And they help to prevent cancer. If you have cells that all of a sudden go rogue and start forming antigens on the outside of them, that cancer cells are cells that go out of control and undergo many rounds of mitosis uncontrolled, unchecked. Well, usually on the outside of those cells, they have normal antigens, and our white blood cells will creep along and say, oh, this is part of me, everything is fine. But cancerous cells tend to have their receptors on the outside change. And so these lymphocytes can take hold and fight them before you develop cancer, kill those cells before they develop into a tumor. So yay, lymphocytes. Okay, our monocytes. This is our second agranulocyte, and it's the third most abundant. It's called a monocyte. This is what it looks like in the blood. Notice this beautiful nucleus. Hope that's what it looks like for you on the lab practical. I try to make it obvious. Notice the size between this red blood cell and the monocyte. It's very large. These guys live for several months, and they are phagocytic. Once they get in the blood, they look like this. In the tissues, you see the word macrophages. They go out, they're big eaters, and they'll slip through the walls. Remember, extravasation or diapetesis, and they'll strip through the wall, and they'll go towards things using positive chemotaxis and amoeboid motion and eat them. They're called macrophages once they're in the tissues. Okay. I think these are another guy that is very active in viral infections, or if you have chronic, meaning long-acting bacterial infections. There is a difference between an acute infection and a chronic one. A chronic one tends to be one that slowly comes on and takes forever to battle, or it can be persistent for a long amount of time. An acute bacterial infection, or any acute infection, is something that, boy, you know it fast, super fast. You have really bad symptoms. It comes on fast, and hopefully that your body can fight it off. Look up the difference between acute and chronic illnesses. If you can live with it for years, it's a chronic illness. Okay, now, so some leukocyte disorders. Anytime we have too few white blood cells, and this is not lymphopenia, this is leukopenia. So that means too few white blood cells overall. The whole white blood cell count is low. It can be from drugs, and I don't mean like, it could be like maybe you're taking cortisol. It could be through anti-cancer agents, or it could be for a variety of reasons. You could have leukopenia for many different types of reasons. So the leukopenia, just the term, means having a low white blood cell count. And if you've ever had mononucleosis, this is caused by the Epstein-Barr virus. And the Epstein-Barr virus, basically until COVID came along, I don't think that many healthcare professionals understood the gravity of the Epstein-Barr virus. It causes mononucleosis, or mono, the kissing disease, and you get a lot of abnormal agranulocytes, meaning the lymphocytes and the monocytes, but you have this wide effect throughout the entire body. You can have an enlarged spleen, splenomegaly. You get a really bad sore throat. You get the fever. You get tired for months on end. If you've ever had mono, you know how many different things can occur. And that's caused by the Epstein-Barr virus, and some people don't have immunity against this virus and can get mono many times over and over again. So look at mononucleosis and the Epstein-Barr virus linked to chronic fatigue syndrome. Because now we have like long-lasting COVID. This is like long-lasting Epstein-Barr virus. People who have Epstein-Barr virus, who have mono for years, can have issues. And it's just been under-recognized until now that we have long COVID. Okay, leukemia. Leukemias are the cancer of the white blood cells of the blood. And it's the only cancer that doesn't have a tumor. If we develop skin cancer or lung cancer or any cancer in the body, there's going to be a tumor, a mass of cells that went rogue and produced a tumor. On the other hand, when it comes to leukemia, there is no tumor. But what happens is you have one of those stem cells, either the hematocytoblast or the myeloid stem cell or the lymphoid stem cell. They go rogue and start producing white blood cells that don't work, and it crowds out the bone marrow. So you have a huge amount of white blood cells that aren't doing their job, and they're crowding out the production of red blood cells, and they're crowding out the production of platelets. So if that's the case, and you can't produce erythrocytes, then you're going to be anemic if you've got leukemia. If you can't produce your platelets, then you're going to have easy bleeding and easy bruising. And then you'll have lots of infections. Those are three massive signs of leukemia, and it's all from these white blood cells that are being produced out of control, and they're not doing their job. If you hear the term myelocytic leukemia, then it's from that myeloid stem cell line. If you hear the term lymphocytic leukemia, it's from the lymphocytic stem cell line. I say refer to slide 7, but if you don't have this PowerPoint, how can you do that? Go back to the lecture where we go over hematopoiesis. We can have acute leukemias. What if we had ALL, acute lymphocytic leukemia? This acute means it comes on fast. It's usually in youth. And the second part refers to the cell line. Acute lymphocytic leukemia is going to be coming from this lymphoid stem cell, and go back to that lecture. I didn't go that specific in the lecture, and look down the line, and you'll see how those the lymphocytic stem cell turns into a variety of the lymphoblast cell. And so that blast, any cell with the name blast in it, if it goes wrong there, then it's going to be acute cancer. If it's down further in that line, after those blast cells have turned into cyst, then we're going to end up with a chronic type of leukemia. And this tends to happen in elderly people. It's acute, fast acting, tends to arise from those blast cells. If you had acute myelocytic leukemia, then it would come from this myeloid stem cell that little line of origin, and it would come from the blast cells within that line. If it's down further, from the site cells, and you would get a chronic leukemia. Elderly, more like happening in the young. Okay. I don't feel like I gave that justice, but that's where we're stopping the white blood cell lecture today. If we can stop it.